Hello all. Today's our topic of presentation is disseminated intravascular coagulation, which is an acquired coagulation disorder, and I will be discussing this topic in less than 10 minutes. So be attentive. What is disseminated intravascular coagulation? So DIC is always a secondary complication and not a disease itself. Actually, it is a paradox because the body is doing two opposite things at once, that is clotting too much and bleeding too much. The alternative name for DIC is consumptive coagulopathy, which means the body consumes all of the clotting factors uh, that leads to depletion of clotting factors and platelets, and this leads to bleeding. So it is, remember that it is not a disease by itself, it is always a secondary complication to many of underlying disorders, and the body consumes excess clotting factors and platelets, and there is consumptive coagulopathy. So DIC is a widespread thrombohemorrhagic disorder secondary to a primary trigger. So what are the etiologies? The major etiologies are infections, which are the most common, mainly gram-negative bacterial sepsis, also meningococcemia, then fungal and other severe viral infections. Mainly the gram-negative bacterial sepsis, and obstetrics complications like abruptio placenta, retained dead fetus, amniotic fluid embolism, in which amniotic fluid enters the blood vessels and causes embolism, in preeclampsia or toxemia. Then certain neoplasms also causes DIC. Mainly you have to remember is acute promyelocytic leukemia and carcinomas of pancreas, prostate, lungs and stomach. Most important, acute promyelocytic leukemia. And also in case of massive tissue injuries like major burns, extensive surgeries, and also in bone fracture, fat embolism can occur, that can also lead to DIC. Other causes include transfusion reactions, snake bites and heat stroke. So the pathogenesis, first I will explain the pathogenesis by this diagram, then we will see the PPT. So pathogenesis, the main causes are actually endothelial injury or the release of tissue factor into the circulation. The tissue factor is a procoagulant, so whenever there is a tissue injury or tissue injury, the procoagulants enter the circulation, that can activate the coagulation, and that leads to formation of circulating thrombi. And also when there is an endothelial injury, there is exposure to the subendothelial tissue that causes platelet activation, and that also leads to circulating thrombi. So the circulating thrombi can leads to much more pathologies. So circulating thrombi can cause thrombotic occlusion of microvasculature of all organs, that can lead to ischemic tissue necrosis and organ failure. Then when the RBCs flows through the microvasculature, some RBCs are trapped in the thrombi and they undergo fragmentation, that leads to formation of schistocytes, which are fragmented RBCs, and this condition is known as microangiopathic hemolytic anemia. Also excessive thrombi formation can lead to activation of secondary fibrinolysis. Due to excess clot, there is excess activation of fibrinolysis by excess activation of plasmin, and this leads to excess of fibrin degradation products, and these fibrin degradation products or FDPs has anticoagulant action, that can also lead to bleeding. And also due to excess consumption of coagulation factors in the formation of thrombi, and also due to excess consumption of platelets, there is consumptive coagulopathy, which means due to consumption of platelets and clotting factors, there is a coagulopathy that leads to bleeding. Now let's read about the pathogenesis. So pathogenesis, the the initial phase consists of two steps. The DIC is initiated by two major mechanisms. First one is entry of a thromboplastic substance into circulation. Uh, so there is a thromboplastic substance or a procoagulant substance like tissue factor released into circulation from injured tissues or tumors, and this tissue factor forcefully activates the coagulation cascade. And uh, widespread endothelial injury is the second mechanism. Whenever there is widespread endothelial injury, there is exposure to the subendothelial collagen, and that leads to widespread platelet activation and aggregation and clot formation. So after this initial step, to that initial steps leads to two simultaneous problems. Those include development of thrombi and hemorrhagic diathesis. So there is formation of fibrin platelet thrombi in the microvasculature that can lead to thrombotic occlusion of microvasculature and tissue hypoxia and then multi-organ failure, and also due to the fragmentation of the RBCs trapped in these thrombi, there is microangiopathic hemolytic anemia in which schistocytes are seen in the peripheral smear. The RBCs get sliced as they pass through the fibrin meshes in the microvasculature. Next is hemorrhagic diathesis that presents as bleeding. So bleeding occurs due to consumption and also secondary fibrinolysis. Severe depletion of platelets and clotting factors can lead to bleeding, and also plasmin is activated to break down the excess clots, generating excess fibrin split products or fibrin degradation products, and these FDPs act as potent anticoagulants which worsens the bleeding due to consumption coagulopathy. Now this diagram shows the pathogenesis in an easy way. It is a summary of the pathogenesis. So tissue or endothelial injury leads to coagulation activation, that leads to circulating thrombi. So this is the initial step. Tissue or endothelial injury leads to coagulation activation, and circulating thrombi is formed. So and consumption of clotting factors and secondary fibrinolysis leads to severe bleeding. Then microvascular thrombosis leads to ischemia and microangiopathic hemolytic anemia or MAHA. So you have to remember this. You must remember this. This is very important. And now the clinical features. The presentation can be serious and is often fatal. The symptoms fall into two categories. First is hemorrhagic diathesis or bleeding. Next is microvascular thrombi that leads to ischemia. So most common manifestation is bleeding. So petechia and ecchymosis can be seen on the skin. We can see bleeding from the mucous membranes, oozing of blood from IV lines, venipuncture sites and surgical wounds. Then microvascular thrombi that leads to ischemia, tissue hypoxia and multi-organ failure. Most commonly kidneys, brain and lungs are involved. Now what are the laboratory findings? So because factors and platelets are consumed, all major parameters are abnormal. The platelet count is decreased, and bleeding time is increased due to decrease in platelets. Prothrombin time is increased due to consumption of clotting factors. The APTT is also increased due to consumption of clotting factors. The thrombin time is increased due to decreased fibrinogen, and fibrinogen levels are also decreased because of fibrinogen is converted to fibrin in the for the formation of widespread clots. So what are the confirmatory tests and peripheral smear findings? The specific test for DIC is D-dimer test, and D-dimers and FDPs, fibrin degradation products. These are formed in fibrinolysis, D-dimers and FDPs, and the D-dimers and FDPs are markedly increased, and which is highly specific diagnostic test for DIC. And the peripheral smear shows Microangiopathic hemolytic anemia, uh, that is presence of schistocytes or fragmented helmet-shaped RBCs, and these are formed due to the slicing of RBCs when they pass through intravascular fibrin threads. Now the prognosis and management principles. uh, Mortality is very high, and very high in severe and acute cases, and uh, the prognosis actually depends on the underlying primary disorder. DIC is always a secondary complication, and prognosis depends on the primary disorder. And for the treatment, we have to treat the root cause, that is, uh, if the root cause is a retained dead fetus, we have to remove the dead fetus. We have to treat sepsis with antibiotics, and treating the root cause is the most critical step. And supportive therapy includes replacement of clotting factors by fresh frozen plasma and platelets as needed. So, summary: the prothrombin in DIC, the prothrombin time, APTT, bleeding time, thrombin time, D dimers, FDPs are all increased, and platelet count and fibrinogen are decreased, and the blood smear shows schistocytes, and the pathogenesis is that there is a trigger, that is tissue injury or endothelial injury or a thromboplastic substance released into circulation that leads to widespread clotting, that leads to consumption of factors, and that leads to severe bleeding. So this is all about DIC. Thank you all.